Welcome to the DIM 400 lectures on fracture healing and complications. I am Dr. LaRue and I'll be presenting these lectures. There are two types or main types of fracture healing that occur. Primary healing occurs with surgical intervention, such as using a plate and screws. This occurs when new bone forms directly between the fracture fragments, so there's no cartilage stage and there's no visible callus. This can only happen with rigid fixation with excellent anatomical alignment and reduction. Secondary bone healing or indirect bone healing occurs with non-rigid fracture fixation, for example, a Robert Jones bandage. The fracture ends are close to each other, but they're not opposed, and so some micro-movement is possible. This is the most common type of healing, and bony bridging callus is visible. Secondary fracture healing is by far more common in animals than primary bone healing. At the time when the long bone fractures, there's also damage to the surrounding soft tissues and disruption of the bone's medullary blood supply. A local hematoma forms at the fracture site, and this hematoma contains variable chemical mediators from the bone itself and the surrounding tissues, which simulate or stimulates bone healing. These chemical mediators stimulate mitosis, differentiation of mesenchymal cells, and angiogenesis. Sources of new cells and blood vessels include the periosteum, the endosteum, and the damaged surrounding tissues. Granulation tissue forms between the fracture ends after a week and results in vascularization of the hematoma. Progenitor cells in the granulation tissue differentiate into fibroblasts and chondroblasts, which produce a matrix of fibrous tissue and cartilage. Woven bone is deposited within this by osteoblasts, and over time the bone will heal. Fracture healing is a continuum of events. So initially the fracture will happen and a hematoma will form at the fracture site. As angiogenesis occurs within the hematoma, some bone resorption will occur after about 5 to 10 days, and this is seen then as a widened fracture gap and loss of crispness of the edges. By the end of the first week, the hematoma is resorbed unless there's infection, excessive motion, or extensive necrosis of the surrounding soft tissues. With time, callus will start forming endosteally, so on the inside, and periosteally on the outside, and this will start to mineralize. And this is seen within 2 to 3 weeks. After 6 to 8 weeks, the mineralized callus is bridging callus, so the fracture is bridged, and eventually, round about that time, the fracture will be healed. Thus, the radiological evolution of fracture healing is as follows. After week 1, there's widening of the fracture gap, and the fragments lose their sharpness, and this is because of necrosis of the ends. In this example here, there's quite a bit of soft tissue swelling over the radius and the ulna, and if you look carefully, these fracture margins are quite sharp still, so the age of this fracture is less than 1 week old. At 2 weeks, immature callus becomes visible due to flecks of mineralization, but the callus does not cross the fracture line. Here's an example of a tibial fracture. There's quite a bit of soft tissue swelling still in this region, and if you look compared to the previous slide, these fracture margins are not as crisp, and there's a lot of fluffy mineralized new bone associated with the cortex, and this is immature callus that one can start visualizing. By the 3rd week, the immature callus becomes more dense and has a fluffy appearance due to increased mineralization. The fracture can cross the fracture line. For example, here, you can see all of this mixture of new bone here is callus formation because it's less opaque than cortical bone, and the fracture line here is still visible. Between 4 to 8 weeks, the callus ossifies and becomes mature. So in this example, most of the callus that is bridging the fracture line here is a similar opacity to the cortical bone, with a few regions that are slightly less opaque. The fracture line has disappeared and the cortices are continuous. It's important to remember that one always needs to take 2 orthogonal views to confirm this. From week 9 onwards and over the following years, remodeling will take place according to Wolff's law. This is whereby axial loading of the long bone stimulates osteoclastic activity and bone resorption on the convex side of the bone, and osteoblastic activity and new bone formation on the concave side. Here's just another example with a close-up of a fracture that's about 10 to 14 days old. Note all of this immature, fluffy new bone that's closely associated with the cortex, and this is immature callus. So on the slide, we'll just look at a few features of callus formation. We've said mature callus is the same opacity as cortical bone, and immature callus is less opaque, as demonstrated in this image. All of this callus here is not the same opacity as the normal cortical bone. Callus should be intimately associated with the cortex. Essentially, it means it should be stuck to it. And the size of the callus is determined by the age of the patient, as well as fracture stability. Young animals tend to produce more callus than older animals, as their periosteum is much more active. And fracture instability can lead to motion and more callus formation. This is an example, or seen in this example, where this fracture has been fixed with a Robert Jones bandage that one can see on the outside. And there will be some micromotion here, and this will stimulate more fracture callus formation versus fixation that is more rigid. There are some important terms we use to describe the stage or state of fracture healing. Clinical union means that mature bridging callus has formed and the fracture is healed. Delayed union means no bridging callus is seen within 4 weeks in a young animal and 6 weeks in an older animal. Non-union means that there's no mature bridging callus seen by 10 weeks. This is very subjective, and one needs follow-up radiographs to determine this over time. An accurate history is also important so that you know when the fracture has occurred, as well as what treatment has been applied in between. And we'll get back to this a little bit later. Primary bone healing can only occur if there's perfect anatomical reduction and the fracture fragments are held rigidly together, i.e. by surgical intervention. The cortical bone is directly repaired without the intermediary fibrocartilage tissue and endochondral ossification processes across the fracture gap. Radiographically, there is gradual disappearance of the fracture line without the formation of external callus. So in the example here, the proximal radial fracture has been repaired with a dynamic compression plate. So the bones are very closely aligned and compressed against each other. And thus, in this case, no fracture callus will form. Direct bone healing, or primary bone healing, consists of contact healing, which occurs under the cis cortex. And the cis cortex is that cortex that is beneath the plate. And gap healing. Gap healing will occur under the transcortex, and that is on the opposite side where the ends of the screws are placed. Contact healing occurs directly under the bone plate because the fracture edges here are under compression. Osteoclasts form cutting cones or resorption cavities at the ends of the osteons closest to the fracture site, and these cutting cones progress across the fracture site and form new osteons that traverse the fracture line. Osteoblasts form the rear of the cones so that bony union and haversion remodeling will occur simultaneously. New lamellar bone is formed, orientated in a normal axial direction, which is parallel with the long axis of the bone diaphysis. Gap healing occurs where there is a very small, less than a millimeter gap between the bone ends. It happens under the transcortex because there's less compression of the fragments together. The new bone that fills the fracture gap is woven bone, and it's initially orientated perpendicular to the long axis of the bone. It then undergoes haversion remodeling and the longitudinal reconstruction. This remains a site of weakness until it's remodeled and integrated into normal lamellar bone architecture, and the cortex is completely restored. The radiological findings of primary bone healing are very different to that of secondary bone healing. In week 1 to 2, we generally don't see any change. After week 2 to 6, there might possibly be a wider fracture gap and loss of crispness of the edges, because some bone resorption and necrosis will still occur. By week 7 to 12, the fracture line will start disappearing, but a phenomenon of stress protection may occur. This is bone loss due to reduced stress and impairment of venous drainage of the bone underneath the plate, causing local osteoporosis to develop, and this may lead to refracture of the bone following removal of the plate. By week 16, the fracture line should be invisible, so the bone should be healed. Stress protection can still occur. The disadvantage of primary healing is that it's difficult to assess due to the lack of callus on radiographs, and it tends to take longer than secondary bone healing. Now we get back to a further discussion on delayed union, non-union, and malunion. So delayed union just means that the bone takes longer to heal than it should. This could be due to many factors, for example, infection of the fracture, instability of the fracture, metabolic or nutritional conditions of the animal. The rules of thumb are 4 weeks in the young animal and 6 weeks in the older animal. Delayed union may continue to a non-union, and non-union is split into viable and non-viable. A viable non-union, or a vascular non-union, means that the bone still has the possibility to heal, whereas a non-viable non-union implies that the bone is inactive with lack of vascularity and it won't heal without surgical intervention. Malunion means healing has occurred in an abnormal anatomical orientation. So all non-union fractures first will go through a delayed union phase, and then they are classified as being viable or non-viable. Determination of non-union is subjective, but it relies on the lack of progression of a healing callus, lack of remodeling of the callus at the fracture ends without bridging, there's increased opacity of the medullary ends, and the duration of healing process takes longer than 10 weeks. Non-unions may be viable or non-viable, as I've said, depending on the stability of bone and the blood supply at the fracture site. Surgical intervention with improved stabilization and possibly bone grafting is used commonly to increase the chance of a successful union. So viable non-union is classified according to the amount of callus present. Hypertrophic viable non-union means there's abundant callus, but it doesn't bridge the fracture gap. Fibrous tissue and cartilage between the fragments remain as a result of continuous motion. With minimal callus, viable non-union, some callus will form, but it doesn't bridge the fracture gap. And with no callus viable non-union, there's little to no callus formation, and the bone ends are bridged by fibrous tissue that cannot become mineralized through endochondral ossification to form bone. Non-viable non-union is characterized by a lack of adequate blood supply at the fracture site to such an extent that healing is greatly impaired. We will get back to the classification of non-viable non-union after the next few slides. The hypertrophic or elephant's foot callus means, as I've said, there's abundant callus but doesn't bridge the fracture gap, for example, in the image on the left. This usually occurs with rotational instability, and commonly at the humerus and the femur, with transverse or short oblique fractures that are treated with an intramedullary pin. The IM pin might help to reduce the fracture, but it doesn't prevent longitudinal rotation about it. Minimal callus, also called horse's foot callus, shows some callus formation. For example, in the images here, there is some callus present. It's just not as much as the previous slide, but it doesn't bridge the fracture gap. This again occurs to rotational instability most commonly, and this is more commonly seen in the radius and ulna or the tibia, fixed by IM pins or an external fixator. Non-callus means that there's no or very limited callus formation. Again, example in the image here, we don't see any callus present and the fracture gap is still clearly visible. This usually occurs due to rotational instability and commonly seen in the radius, ulna, or tibia. Also because these distal limbs tend to have less soft tissue covering over them and less source of blood supply. Non-viable non-union is classified according to dystrophic, necrotic, defect, or atrophic classifications. In each, there's an obstruction to healing. With dystrophic non-union, an intermediate fragment has united with one of the main fragments, but not with the other. Vascularization of the intermediate fragment can take place from one side, but this devitalized bone creates an obstruction. The white line in the image over here presents a medullary cavity that's sclerotic and has been sealed off, indicating that it is non-viable. Necrotic non-union means that there's dead bone in between the viable fragments. The dead bone in this image you will see is much whiter than the rest, so it means it's sclerotic because it's dehydrated and it's lost its blood supply. We'll get a little bit more into this when we do osteomyelitis. With defect non-union, there's a large piece of bone that's missing, so there's just no way for the tissues to bridge this. And atrophic non-union is rare and usually is a sequel to any one of these three previously discussed ones. It's radiographically characterized by loss of vascularity, loss of bone, so bone resorption, rounding of the fracture ends, and osteopenia. It's seen most commonly in non-union fractures of the distal radius and ulna in toy breeds, especially because they've got the least blood supply in that area. So just to recap, unfortunately, these are quite uncommon, so I don't have any radiographs of these. We've mentioned dystrophic non-union, an intermediate fragment has united with one of the main fragments, but not with the other side. Necrotic non-union is again very uncommon, so I don't have an image, unfortunately, but it generally involves comminuted fractures. So there are many smaller pieces of fragments as a result of the fracture, and this can result in some of these becoming necrotic, and then they obstruct healing. Callus will not bridge the fracture gap, and this again is often due to rotational instability again. Here's an example of a defect non-union. There's a significant loss of bone between the fracture fragments, and it's just too big for callus to bridge it. In these cases, bone grafting might have to be considered. And what's shown here is that there's sclerosis of the medullary cavity on either side, more noticeable of the proximal fragment, and this indicates that there's no healing potential left. And with atrophic union, it results as a sequel to any one of the others, typically in toy breeds. With the image on the left, with the fracture of the radius and ulna, you'll see that there's rounding of the fracture fragments here. They almost become a little bit pointed, and fracture will be older than 10 weeks, showing no progression. In the image here of the tibial fracture, the distal fracture fragment is rounded. It shows marked loss of bone. The proximal fragment shows a spike formation, and that's just another example of atrophic non-union. With malunion, the fracture fragments will heal, but in a non-anatomical bone alignment. With functional malunions, there are only small deviations from the normal axial alignment of the bone, and these animals will cope quite well. With non-functional malunions, excessive stresses may occur on the joints associated proximally and distally with the fracture margins. This is because these malunions might have healed with external rotation, valgus or varus angulation, and eventually will result excuse me, in secondary DJD of the joints. In especially young animals, a condition worth mentioning is rhino horn callus. Rhino horn callus occurs due to periosteal damage or periosteal stripping. The most common site we see this at is the insertion of the adductor muscle on the caudal femur. This creates a bridge of callus, which will extend along the caudal aspect of the femur, and the bone will form beneath the elevated and damaged periosteum. It's particularly important and seen in young immature animals because the periosteum is very active. In this image here, the fracture had happened up here, proximally, and with concurrent damage to the adductor insertion, the periosteum was stripped up and formed abundant callus here, And this fracture also has a lot of gas lucencies coalescing within the soft tissues and with a very high possibility that is infected. The image over here is just another example of a fracture that's occurred in the femur with periosteal stripping and a large rhino horn callus present. Radiographs are also important to evaluate fracture healing. Generally, radiographs are taken immediately post-operatively and then at least every 3 weeks. It's sometimes taken a little bit sooner in young animals where it will heal very quickly, or sometimes it's stretched out a little bit if it's a mature animal where healing takes a little bit longer. We use ABCDs of fracture healing to assess the fracture site so that we remember to look at everything. A stands for alignment of the fracture segments. B is for bone healing and the degree of callus formation. C refers to the cartilage present. Implant should be away from the joint and not be penetrating the joint. For example, in the image here, the IM pin is within the anterobrachiocarpal joint. Cartilage also refers to fractures that have entered the joint space, and also physial fractures. Device refers to the appearance of the implant, and we look to see if there's adjacent lysis, which might indicate loosening or infection, or if there are positional changes indicating migration or fracture of the device. For soft tissues, we look for soft tissue swelling, emphysema, which might indicate infection, and soft tissue atrophy. Implant failure can occur post-operatively. Luckily, it's not common, but the implants may move and loosen. The implants may break or they may bend. In the example on the left, the screw has loosened and pulled out, likely because it was placed within the fracture site. And the image on the right, the plate has broken through and with refracture of the radius and ulna. And if you look carefully at the ulnar fracture fragments, they're quite spiky and pointed, and this might indicate that the ulna has formed an atrophic non-union. Radiolucencies around the implants need to be carefully looked for. They could be due to movement of the implant, infection around the implant, or heat necrosis. Heat necrosis is very uncommon. In the example on the right-hand side here, there is a radiolucent zone outlined by my little marker, and the arrow indicates a sclerotic bone fragment here. This is due to sequestrum formation. So the sclerotic fragment is a dead piece of bone, and the radiolucent area around it is a region filled with purulent material. So this will be an osteomyelitis associated with fracture repair. And we'll discuss all of this a little bit more when we look at osteomyelitis in that lecture. So for the fracture quiz, I'm going to go through a few cases, and you can describe the findings and make a diagnosis. And it's important to remember when describing the fracture, you need to tell it like a story, as if you're describing it to somebody who can't see what you're looking at. So here's the first fracture. You can hit the pause button, and then I'll go on to the next slide and describe what's going on. So this is a Salter-Harris type 2 fracture. I can see that it's a skeletally immature cat. You can see the physes are open. So in these cases, I must immediately remember to look for growth plate fractures. On the craniocaudal view, it's probably the best seen that the fracture extends through the undulating physis of the distal femur, and then it extends proximally into the metaphysis of the medial distal femur. This round structure over here is the patella that's superimposed in this region. And here's the next case. So this is a comminuted mid-diaphyseal humeral fracture secondary to gunshot injury. The metallic opacities seen here are all the fragments coming from the bullet. And I can say with further description of the fracture that there is cranioproximal displacement of the distal fracture fragments. So this should be considered an open fracture due to the gunshot injury, and there is a lot of soft tissue swelling surrounding the fracture as well. So this is the next case. The history in this case is that the fracture occurred about 3 months ago, and the patient was treated with a Robert Jones bandage. So in this case, it's a viable non-union with minimal callus or horse's foot callus formation of the distal radius and ulnar fracture. You can see that there is some callus that's present, bulging outwards, but it doesn't cross the fracture line. In this case, the fracture margins are also not crisp, and with the amount of callus formation, we can already say that it's not a recent fracture, and this has been going for a while. It is most likely because there's too much motion at the fracture margins and that the Robert Jones bandage doesn't support adequate, or doesn't give adequate stabilization of this fracture. In this case here, there is a proximal radial subluxation in a cranial direction, and there is a short oblique mid-ulnar diaphyseal fracture with mild caudal and proximal displacement of the distal fragment. This is called a Monte Jia fracture, and this is a very specific type of fracture subluxation occurring in the antebrachium. The definition of this is a proximal radial subluxation concurrently with an ulnar fracture. All right, so on this case, one can see there's a moderate amount of soft tissue swelling focally over the radius and the ulna, most severely dorsally and laterally, and affecting most of the mid-ulnar diaphysis. There is quite a marked amount of permeative lysis affecting the bone, with thinning of the cortex and loss of the cortex in places, and there is a fracture extending through it, with a bit of callus formation caudally, but it's not bridging. So this would be consistent with a pathological fracture. The bone itself is diseased and weakened by the tumor in this case, and with the result, there's fracture of the bone. There's also a radial fracture. The bone of the radius appears pretty normal, so the radial fracture is probably secondary to the ulnar fracture and due to weakening or loss of strength of the bone as a unit. Right, so this case demonstrates a proximal radial subluxation. The proximal radial radius, or the radial head, is displaced in a lateral direction. And then there is a recent transverse mid-diaphyseal radius and ulnar fracture. Fracture margins are crisp, so we can say that it is recent. And there's moderate proximal and cranial displacement of the distal fragments. If you want to describe it a little bit more, you could even say that the radial subluxation here results in the proximal ulnar radius being angulated from proximolateral to distomedially. In this case, we have a VD extended radiograph of the pelvis of a cat. I can see that the distal femoral physes are still open. So immediately I know it's a skeletally immature animal and I must be aware and look out for Salter-Harris fractures, which is exactly what has happened here. There is a fracture, Salter-Harris fracture 1, through the proximal femoral diaphyses, or the femoral head, or the femoral physes, and there is moderate cranial displacement of the distal fracture fragment, but there's no orthogonal view for us to further describe this fracture. In this case, again, it's a skeletally immature animal. The open physes are visible. And so we have a chronic a Salter-Harris type 1 fracture. So it's just gone through the distal physes of the femur. I can say that it is chronic, or at least in this case, I would say about 2 weeks old, because the fracture margins are really not very crisp and it looks a little bit fluffy. So there might even be very early callus formation associated with it. There is moderate caudal displacement and angulation of the distal fragment relative to the proximal fragment. All right, and the last case just demonstrates implant failure. There is a fracture of the intramedullary pin at the site of the initial or the original proximal radial diaphyseal fracture. This is likely because the IM pin was too thin in this case. There's also a concurrent proximal ulnar diaphyseal fracture at the same level, which in the first case would, or the original repair would not have been repaired, and that's quite common surgically to have the ulna not repaired at the same time. Right, so that's the end of this section. And next we will be going on to osteomyelitis of the bone.